So the next speaker we have today is Dr. Deepak Mishra, and thankfully I do not need to introduce him. He has been doing it for the last 3-4 months, courtesy AIOC election. So Dr. Deepak Mishra is going to talk about the penetrating ocular trauma. Thank you, Dr.
Thank you, Dr. Mamta, for including me in your IC. There is no financial interest in this talk. Here everywhere there are different classification, but for the international classification guidelines, we have either it's open globe or the closed globe injury. And the topic Dr. Mamta allotted to me is the penetrating injury. So there is only one confusion, means when we say it is a penetrating or when it is a perforating. When there is one entry wound, means there is something which goes inside but not there is a outside track, then it is known as penetrating. And when there is both, means either both wounds are present, entry and exit, then it is a perforating. So another one is why it is important to know or manage the penetrating injury. So when we go for the epidemiology or the data, then we find out that it is the almost the most common unilateral cause of loss of vision, and that is not the important thing that it is the cause of vision. Important is that 90% of them can be prevented, means it is a preventable cause of disease, the vision, and if we have some knowledge or good knowledge, we can prevent it. So whatever the vision loss is there by this penetrating injury, so we can reduce the burden too. And most important is that 50% of them are less than the 25 years of age, and 34% are of the pediatric age group. Again, I am saying these type of penetrating injuries are more common in the pediatric age group. We all often see that someone hit by pencil, some another thing, or different kinds of injuries are there in the pediatric age group, and they required GA. That is another problem for those for management of their injury or their perforation, because we have to depend upon the anesthetics and at least 6 hours empty stomach, different status are there, GA requirements is there. But knowing the data and the prevalence, we can have some better vision there. What happens, these type of penetrating injuries have different kind of effects. One is the mechanical, what I have just tell you all, that there may be the laceration, or sometimes there is tear may be in the cornea, corneoscleral, sometimes up to the retina if there is high moving sharp objects are there, sometimes vitreous hemorrhage and different things. So these are the mechanical effects that is caused by the agent which from which we got the injury. But another one which is not less damaging is the introduction of infections along with these track, because you know the whole eyeball is protective for us. When you have damage somewhere or anywhere, then there is chances of growth of the infections inside. And if not in this side, not properly managed one eye, then another eye, that is another sympathetic ophthalmitis, means we these penetrating injuries directly damage something, then there may be chances of infection with them, and if all them not at present, then later on there is a chance of sympathetic ophthalmitis, means all sorts of vision loss or the possibility are there with these penetrating injuries. Now most important what I can say is the evaluation. Evaluation is very much important, because we have to rule out what is the cause. Not only the ocular cause, but the non-ocular causes of injuries can also be kept in mind. Another thing is time and place. What happens most of the time in adolescent or even the child, these injuries are may lead to the medical legal issues or something. You can say FIR is there or police case is there, someone hit to someone. So date, place and timing of injury is very much important, not only for the management but also to save us from the medical legal issues later on, or for the child too. Another is this check the vital signs, because if these are the pediatric age group or another age group, so you have to um, take consent of the anesthetics to do, so they will do each and everything. Also not only examine the corneal part but also examine the external injury. Most of the time we forgot to find out something which happens. I am tell you one example in which there is small corneal perforation in my OPD, and we said it's easily repaired by one suture, something like that. But the boy has hit on the back of the scalp too, and that is the reason for the loss of the vision. And we are unable to searching or taking history why there is no vision, no vision. He or she is happy. There is a pituitary damage in that eye boy, and gradually we are searching why, because of such a small perforation there is loss of vision. So these external examinations will tell you how important is the examination of whole face or the scalp or the brain injury too, along with these injuries. Another one is whenever you have to record the visual acuity of both eye. That is the most commonly uh, mistaken point in the all the medical legal cases, that when you are examining or doing something, you miss the examination of another eye. Sometimes we have a habit of writing ODOS or up and right arrow, but we ophthalmologists know means up is right and down is left. In the court case or any of the other medical legal cases, we forgot. Or sometimes we, if not writing clearly right eye, left eye or ODOS, then we again himself forget that vision is of which eye, though that is the important for each and everyone. Now coming to the individual evaluation, before going to management in a brief, whatever the things is possible, do by the torchlight assisted with the slit lamp examination. And slit lamp examination in the cornea, what we can say, we have to look out each and every point, means even in the conjunctiva, foreign body, where hemorrhage is there, laceration is there, cornea defect. And whenever we find out any corneal perforation, then try to elaborate or make a diagram or whatever is the possible handmade diagram, what is the length, depth or width of the injury. Scleral, again laceration and rupture both. Anterior chamber, apart from the normal things, look for the foreign body if you are expecting something like that. And same the iris and angle, what is the type of wound, whether iris is attached or not, any iodolisis is there or not. So these are the common points I summarized for we have to in mind when looking for the injuries. Same for the lenses, whatever the position of lens, whether dislocation, breach in continuity or axis or anything, you have to go for that. Apart from these evaluations, sometimes it's not possible because of the chemosis. Chemosis is the factor, or we sometimes unable to open the lid. In that too, examination is very much important. Whenever is required, either X-ray, USG or CT scan, go for it. Don't be afraid of doing any such investigation, but I'm telling you, these will guide us better and save us in the management too. If it is required or something injury is having more than 24 hours or 72 hours and you suspecting some infection component is there, then also go for the culture of the whatever the tissue you removed, either incarcerated iris or the cornea or the tear film. Again go for the culture and sensitivity, so that after proper repairing you go for the good antibiotic coverage for him too. Now I'm coming to the exact management, which is apart from the beginning or the symptomatic management for the child or the anyone having perforating injury is uh, analgesic, antibiotic, patching, atropine, whatever we are doing is the same, but the principally we have to correct the by the repair of these perforations. So primary repair is of the corneal repair is aim is to have a watertight closure of the globe, whatever is the possible. And second is the restoration of secondary structures. Apart from that, there are many secondary objectives we can say, but two I am saying you everyone should know, that avoidance of any uveal tissue incarceration in wound. That is the most important point when you are repairing this with iris damage. And if any foreign body is there, then at least remove. Try to removal of foreign body is as important as removal of incarcerated iris tissue. So this is just I am trying to make a graph where suture should be placed so that it will be ideal. What you have seen here, if my pointer is there, whatever the depth of the suture, these sutures act as a vector manner. Whatever the height is there, similarly they will go at a 45-degree angle, make here and to here. So the placement of suture and this length both is important. Not only the width but the length of suture is important in the corneal tissue. Just I am saying that because most of the time the edges have the edema, so if you sutured with the edematous part or anything, then next day there may be a chance that either it will be a loose suture or it will be slipped off. So this diagram will help you to understand how suturing should be performed in the different segment. Although it's a very big topic, I'm not going in detail, but just trying to say something that, give me 1 minute more. Here, whatever is the horizontal and the vertical direction, just place the sutures half of the distance of the vertical. Now coming to the corneoscleral suture with iris incarceration, most important is whenever is in the iris tissue is there, first of all you have to irrigate and clean it whatever is the possible as possible by the fluid or the solution, and start if there is a limbus tear, then mostly give a stay suture at limbus, because limbus is the toughest structure. So when you have stay there, you have a good chance that you approximate well both cornea and the sclera. However, the lens is incarcerated or anything, then you have to remove the IOL, whatever is the, if lens matter is there, either by ECC or by same wound or SICS, whatever you can prefer. If we have some IOL implantation or something at the same sitting, usually it is difficult and people avoid IOL implantation at same sitting, but it is small wound, not infected, and you think whole lens material is lost or something sloughed out because of that, then you can go even for the IOL implantation with or without vitrectomy. Now coming to the scleral repair, it is again important as the cornea. What is important is we have to where is the main problem? Main problem is in the sclera. You didn't know just the back extension of the sclera. So we have to start with the anterior point of the sclera where we find out the tear and go slowly and slowly to posterior. Whatever the possible, go for the long waist. So identify first the plane of the dissection, means it will be episcleral tissue and scleral cells separated. You separate, closely separate it till you find out the another edge where the sclera is automatically attached or non-perforated or non-sane. So identify the edge and start suturing from anterior and go slowly and slowly to the posterior. But always try to go as close as possible. Sometimes it is not possible to go close because there's not only the penetration is there, there is rupture of a globe is also there, so it will be more posterior segment. So there we can have to go more posteriorly, but try to find out that there is no distortion or torsion on the globe because of your so much posterior suturing. And sometimes there the perforation or penetration is such a way that it also involves the extraocular muscles. So don't afraid of it. Whatever the repair you have done, you've done, and after that again suture your muscle too, whatever is the possible, so that we sometimes just repair the sclera and forget about the muscle, or sometimes it is not possible to identify that muscle is also broken, some tendon is involved. But we have to look, since we all are knowing the anatomical position of the muscles, so we are knowing that yes, if muscle is involved or not. Even you can check on the OT table too by pulling the muscle like you are doing in a squint surgery, how to repair it. This is the timing I am saying most important factor apart from the surgery, which is not in our hand. It's because sometimes patients come late or delayed, but the timing is as we can do. If it is repaired within 24 hours, it is the best to repair within 24 hours. If not possible, then whatever is the earliest we can do for that. So my take home message is first the proper planning and counseling of the patient, that what is the problem, how is the outcome of the vision, that is important, your presenting vision, and all sort of complications what you are expecting from sympathetic ophthalmitis to easier one like small eye or foreign body sensation or anything, explain to the patient. Timing, again I am saying timing is the important thing, so do it as early as possible. And documentation, I tell you, this is the only thing which save you in each and every point. Sometimes after the good perforation repair or anything, patient said he lost vision because of the surgery. They are not ready to accept that the vision loss is because of the injury or anything. They want that if operation is done, then vision should be 6/6, which is not possible. So at least document the pre-surgical vision if possible, or the post-surgical vision, and also take a proper consent for all medical legal cases, because nowadays perforation is common in the court cases too. With this, I would like to thanks again Dr. Mamta for giving me this opportunity.
Thank you, Dr.
Thank you.
Thank you so much.